Hello, everyone. Welcome to Hot Seat. I'm Omar from Tehran. And once again, I'm so happy to be with you all from this educational platform. Uh, from the very start that we began this Hot Seat series, we've passed almost now 25 sessions, and we have about 15 sessions ahead. And we try to cover different aspects in periodontics, implant surgery, or maxillofacial surgery and prosthodontics. And today we have a great friend and speaker from Italy that we will try to cover atraumatic extraction techniques. And the main focus today is going to be on piezo surgery on impacted teeth, which I believe is a very interesting topic and one of the musts and needs to know to be able to do our surgery atraumatically, which will bring more comfort for our patient. And it's very important to know this technology in different aspects of implant surgery, but most importantly, in one of the very basics, which are the extraction of impacted teeth. So our dear friend, Angelo Cardarelli is here with us from Italy. Hello, Angelo, and welcome to Hot Seat.
Oh, good morning, good afternoon, everyone. Thank you very much. Thank you for your kind invitation.
Thank you, my friend. We are glad to have you on the Hot Seat series, and I'm pretty sure today will be full of knowledge and updates for all the audience around the world. And as a tradition, I will have your CV for everyone, and then we start the presentation, and we will have a discussion at the end. Professor Angelo Cardarelli graduated with law in dentistry and dental prosthetics at the University of L'Aquila in 2007, specializing in oral surgery at Sapienza University of Rome in 2010. He is an adjunct professor and tutor at the San Raffaele University of Milan. He is a scientific advisor to the dental clinic at the Department of ICCS San Raffaele, Milan also. He works in Milan and Isernia, where he practices implant prosthesis and oral surgery. Author of many publications, speaker in national and international congresses on implantology and oral surgery. Member of San Raffaele Implant Cultural Association, SIMO, and member of Italian Academy of Osseointegration. Also, he is the author of a new release book, Piezo Surgery in Impacted Teeth, which I believe he will cover the topic for us today, and so interested to hear about it. So Angelo, thank you again for accepting the invitation, and we are ready for your great presentation.
Thank you very much, and I'm very happy to be here today to spend some of my time with you, with all of you, talking about one of my best topics, the surgical treatment of impacted teeth, a new minimal invasive approach to reduce the invasivity and to reduce the morbidity for our patient. So before we start, I'd like to introduce myself. I am oral surgeon and I come from a small town in the south of Italy, Isernia, where I work in my clinic with my brother and my father. This is my clinic, and I have in my clinic a surgical dedicated room for oral and implant surgery. It's very important to have a dedicated place to make our surgery. And this is my clinic, the fifth floor, also dedicated for pediatric. Our approach is very important in our treatment, always. And I made 1 year ago my academy in Italy, as you can see from this short video. And during the year, I make some courses about the extraction, about the implant rehabilitation with the theoretical part, with hands-on training, and especially with the live surgery, because I think it's very important to see with the live approach the surgical treatment about the prosthetic rehabilitation. And I have many doctors from different parts of Europe and also from US to come in my clinics for the advanced and basic course, as you can see from this promotional video of my academy. And I hope to start again after this particular period related to coronavirus. But I spent some of my time also in Milan as oral surgeon, adjunct professor at University of Milan, University Vita Salute San Raffaele in Milan. And this is my team work. And as you can see on the left, I was editor of the All-on-4 concept, Professor Paul Malo. And I'm glad to be part also of California. And I'm very glad to start a new collaboration and a new fellowship in US, especially with Dr. Arun Garg from Miami and with the International Extraction Academy of California. So this emblematic picture, because as you can see from this picture, in one day I removed more than 15 wisdom teeth. So it's possible to do this surgery with the minimal invasive approach, with the easy and the safe approach, especially using a new technology and a new device like piezo surgery device. Now we can start. The eruption of the dental elements represent genetically controlled events. So during this period, it's possible to have some problems that can cause the alteration of the normal eruption of the dental elements in both arches. In fact, the incidence of the inclusion of the dental elements is about 20%, with a predilection for women. And absolutely the most frequent included tooth is the lower third molar, followed by the upper third molar, followed the upper canine, the lower canine, and then other dental elements. And it's possible to show many factors that can cause the inclusion of the dental elements, local factors and systemic factors. For example, the extraction of the deciduous teeth, because after I removed the deciduous teeth, I don't have the sufficient space in the arches to obtain a good eruption of the dental elements. The ankylosis of the dental elements, the alteration of the follicle and on the germ. And also we have a systemic factor like systemic disease, osteoporosis, dysplasia clavicularia. As you can see, for example, in this case, have a look at this case about a very young patient, 15 years old. And as you can see from this X-ray and from the CBCT reconstruction, we have an alteration of the normal eruption of the dental elements, the persistence of the deciduous teeth, hyperdontia, and many lesions in the mandible and in the maxilla. So, for example, in this patient, it's very important to have a multidisciplinary approach about the surgical treatment, about the extraction, and after about the orthodontic treatment to achieve a good space to place the implant in this patient. So this is the resume about the incidence of the included teeth, the lower and the upper third molar, between 20-30%, as you can see from this image. So it's very important in this subject to have a good knowledge about the anatomy, about the diagnosis, about the X-ray reconstruction. Is very important. For example, in this case, about the vertical lower third molar, as you can see. We haven't a close contact between the roots and the alveolar canal, but as you can see after the extraction, we have a particular shape of roots. So in this case, it's very important to cut the roots and after to extract the dental elements. So it's very important to have a good knowledge about the anatomy and about the X-ray diagnosis to obtain a good surgical approach in all cases, because the anatomy of the included teeth and the third molar especially is more variable, as you can see, with different shape of roots and different number of roots. As you can see about the lower third molar, 3 roots, for example, and the the upper and the lower third molar, as you can see. And this is a particular anatomy about the lower third molar, as you can see, particular shape, particular angulation of the roots. So in this case, it's very important to have a good protocol to avoid the fracture of the roots, the fracture of the bone, especially in the posterior side of the maxilla, where the visibility is very, very lower. So it's very important using a new device to reduce the invasivity and to extract the dental elements with the minimal invasive approach in all clinical cases. And these are the surgical phases. The first step is the anesthesia. Is very important, the anesthesia. And in particular case, I use always, as you will see later during my lecture, the conscious sedation to reduce the anxiety by our patient. The second step is the flaps design. Is very important to choose a correct design according to different type of surgery. It's very important to achieve a good surgical view, and the bone resection and the ostectomy is another important phase. And in this new approach, it's possible to use the piezo surgery device to reduce the bone resection, to obtain the same outcomes, to reduce the invasivity. And if necessary, I will do also the odontomy to cut. And the last but very important phase is the suture, to achieve a good primary closure of our flap, to achieve a good healing of the wounds after our surgery. It is very important to choose a correct type of suture after and during our surgery. So the anesthesia is the first step. And about the lower third molar, I use always the block of the alveolar nerve using the mepivacaine with the epinephrine. Without epinephrine in the first step, about the speak spine, and in the second step, I use the mepivacaine with the top of the buccal nerve around the soft tissue, as you will see later. So I prefer to use the mepivacaine instead of the articaine, because in my hands I noticed that the articaine that can cause more ischemia and more pain during the injection. So I prefer to use the mepivacaine instead of the articaine. And this is our protocol about the particular patient with some allergy. So using this protocol, it's possible to reduce the risk of the allergy. For example, using 3 days before our surgery, this dosage, using the steroid, using the antihistaminic, and with different dosage in the pediatric patient and in adult patient. And there are many studies about the use of the articaine instead to the use of the lidocaine, but there are not more different. But in my practice, as I said before, I use always mepivacaine. And this is our surgical view. During the surgical approach of the lower third molar, it's very important to have a good knowledge of the anatomical structure. In fact, we have in the thickness of the cheek, the facial artery, the buccal nerve around the soft tissue, on the lingual nerve, and it's very important to avoid the injury of the lingual nerve, and in the interior border of the mandible ramus, the spike spine for the direct technique. This is the schematization about the use, the correct approach of the anesthesia. This is the spike spine, as you can see, and this is for a direct technique using a very long needle size to obtain the block of the alveolar nerve. This is also another picture about the schematization of the indirect technique around on the top of the spike spine, as you can see. But in my practice, I use the direct technique, and we have different color of the without epinephrine and articaine at 4%. Two different sides of needle, always these sides and long sides. In my practice, I use always, as you can see from the left, the image on the left, the direct technique with the direct approach, medium needle sides with the direct technique in the corner of the mouth in the opposite direction respect to the site of our surgery, using maybe the first step to block the alveolar nerve. Instead, this is the indirect technique. And after the block of the alveolar nerve, is very important to make another step using mepivacaine with adrenaline, with the epinephrine around the buccal nerve in this site and also in the lingual site, as you can see from this picture. Instead, in the maxilla, I use always the injection, for example, in the palate, about the emergence of the palatine nerve in the posterior side, and in the anterior side, the injection on the emergence of the nasal choose a correct emergence of the anatomical structure to obtain a good analgesia for our surgery. Always. Another example about the injection in the maxilla, in the vestibular fornix. And in extreme case, it's possible to use an extraoral anesthesia, for example, to obtain the anesthesia on the emergence of the extreme and particular case. And also, for example, the perilesion injection, for example, during the enucleation of the fibroma on the soft tissue, using medium needle sites is very important. And as you can see from this short video, is very important, patient with a low compliance, is very important the use of the conscious or the conscious sedation to reduce the anxiety, to reduce the blood pressure, to reduce the bleeding, to achieve a good surgical view is very important, easy as you can see, and is very safe. And also using the conscious sedation, it's possible to inject at the same time the benzodiazepine to reduce the anxiety and also the steroid before our surgery and 4 milligrams immediately after our surgery to reduce the edema and to reduce the swelling and the pain. Is very important, this approach, using conscious sedation according to the general state of health of our patient is very important. And now it's possible to inject the benzodiazepine, as you can see, and after it's possible to start. So I think it's very important the use of, but also for the implant prosthetic rehabilitation in case of a particular patient with particular systemic disease, because it's very easy and safe protocol. And now it's possible to start. We need to have some tools to check the heart activity, to check the saturation of the blood, to check the blood pressure, like life monitor. As you can see, this is the diazepam to do the anesthesia, and also it's possible to use another device to check the saturation and to check the heart activity during the surgery. Is very important. Another aspect is very important to have a dedicated instruments for this surgery, but for all type of surgery. It's very important to reduce the surgical time, to have an ergonomical approach, and to have only each type of surgery. And this is the surgical set, the surgery, the syringe for the anesthesia, the scalpel and the blade for the flap, the needle holder for the suture, and it's very important to follow the correct use of this instrument. Tongue retractor, for example, in the lower third molar to protect the tongue and to protect the lingual flap, to avoid the injury of the lingual nerve. The use of the retractor to protect the cheek, to hold the flap and to protect the facial artery, especially during the use of the traditional drills. The correct use of the periosteel to disconnect the flap. Obviously, in this surgery, I will use always full thickness flap, always. We have in this kit two different types of periosteel: mold with sharp shape, Pritchard, Edson, clamps, hemostatic retractors for the mandible and for the maxilla with particular shape, especially in the posterior side of the maxilla, the retractor for the tongue, and the bite block to achieve a good view with the bite block, because using the bite block it's possible to open without problems the mouth of our patient. And the correct use of the retractors. After I reflected the flap, I used the retractors to hold the flap in the vestibular side and the tongue retractor in the lingual side. So in different clinical cases, we have the same approach and the same good surgical view. It's very important, this approach. And also the device for the suction, the medium size, but it's very important to have a small size, especially when I need to remove the small apex in the small cavity. So it's very important to increase my surgical view, the use of the small size for the suction, and also use this device during the GBR, for example, to avoid the suction of the bone chips. Different type of angulated luxator, different sides, and the bone clamps to remove the bone after the extraction, to remove the soft tissue and the residual part of the enamel, for example, of the soft tissue. And also different luxator with the S shape with this very small sides for the apex. Economical use of the luxator, for example, angulated luxator, straight luxator, and S-shaped horizontal lower third molar, and different forceps for the lower molar, upper molar for the apex, and the Lucas curette to remove the residual parts in the residual alveolar cavity of the forceps in the lower third molar. Is very important to have a dedicated instruments also for the suture and the PCM approach, and different drills with different shape and different materials. For example, I use always on the straightened piece these ceramic drills to reduce the vibration of the bone. Is very important. And this is the correct use of the traditional drills. I use the piezo surgery to make the ostectomy, and after I use the traditional drills to cut the crown and the roots to protect always the soft tissue in the vestibular and in the lingual side. Always different clinical case, but the same approach. Two retractors, always the clinical case. And for this reason, 1 year ago, I made the first dedicated kit for this surgery instrument. This kit, it's divided in two sets, which you can find for this surgery. This is the impacted teeth set. Different luxator, different periosteel, different clamps, different retractors, and a new forceps, as you will see later, with the particular shape, especially for the lower third molar. The second step is a very important step. The choice of the right flaps design, and which flap I will use in the approach, for example, of the lower and upper third molar. I will use always this flap, triangular flap. It's very easy, a simple flap with one horizontal incision and the flap that I use, for example, during the lateral approach in the maxillary sinus lift. And in the extraction of the lower third molar, this is the correct shape of the triangular flap with the one horizontal incision to preserve the papilla between the first and the second molar, intracircular incision, and the one vertical distal vestibular incision to avoid the lingual side. As you can see from this occlusal view, it's very important, the lower third molar, to preserve the lingual side. And after, it's possible to reflect, to disconnect the flap to achieve a good surgical view, easier the suture at the end of the surgery. The same flap also in the maxilla, for example, triangular flap, one vertical and one horizontal incision. For example, in the approach of the lesion of on the upper jaw, and the same approach in the maxillary sinus lift. So it's a very easy and safe flap, as you can see, for example, in the surgical approach of the maxillary sinus lift. Only one vertical incision. Now, this is our view during the approach of the lower third molar, following always facial artery and the lingual nerve. So this is the correct flaps shape. One horizontal white line to preserve the papilla, intracircular incision, and vertical vestibular to avoid the injury of the lingual nerve. As you can see from this drawing, the correct shape of the triangular flap and the path of the lingual nerve. Because in 14% of the cases, this is the emergence of the lingual nerve, very superficial emergence. So in this case, it's very easy to injure the lingual nerve if I don't use the correct flaps design and the correct surgical approach to protect the lingual flap. And also using the piezo surgery insert with the selective cut, it's possible to preserve the lingual nerve and to avoid the injury of the lingual nerve. But likely in 86%, this is the path of the lingual nerve with close contact with the lingual bone site. And as you can see from this cadaver dissection, it's possible to see a very important diameter of the lingual nerve. So it's very important to know these details, this anatomical structure during the approach of the lower third molar. Another cadaver dissection to show the emergence of the lingual nerve. This is the diameter of the lingual nerve. And using the periosteel with the full thickness flap, if is necessary, it's possible to reflect a little bit the lingual site of flap to protect always the nerve with the periosteel, especially during the use of the traditional drills to cut the crown and to cut the roots. And for this reason, by 10 years ago, I started the use of the piezo surgery device with the particular tips according to different type of surgery. For example, these are the tips for the extraction, for the ankylosis roots with the particular shape, and for the osteectomy, these very nice tips with an aggressive cut. The correct use of the piezo surgery device. So in this case, I use the piezo surgery instead to the straightened piece to achieve a good and a very conservative osteectomy. As you can see from this video, for example, very easy and safe approach. So after I reflected the flap, it's possible to make a very micrometric cut around the crown on the lower third molar to preserve the bone. And if I will preserve the bone, I will have more advantage, like a reduction of edema. As you can see, we have a very micrometric and a very conservative cut. Now it's possible to cut the crown and after to remove the dental element with very conservative approach. And have a look, this clinical case about the surgical treatment of the lower third molar in the mesial position, following always the same surgical approach. This is the initial situation. So after the anesthesia, it's possible to make the flap, one horizontal incision, as you can see, and to have this approach. Okay, this is the triangular flap. I reflected the flap and I used the retractor to hold the flap. And now I start with the piezo surgery insert and also using the piezo surgery device, it's possible to make the osteectomy deeper, a good space between the crown and the bone, and after to cut the crown. So in this case, after the very micrometric cut, it's possible to use the traditional drills according to the X-ray pre-op to cut the roots and the crown, as you can see. And now using the luxator, it's possible to remove roots, as you can see, with angulated luxator. And now I will introduce a new forceps comical shape to remove the roots very with very easy approach. And now it's possible to remove the anterior roots. And after, I use always the saline irrigation to remove the residual parts in the cavity. And as you can see, it's possible to see the bone septum after the extraction. So in this case, it's necessary to cut the roots to remove this dental collagen for the hemostatic reason and also to obtain a good plane for the suture. And simple note, without tension, with the good primary closure, as you can see, and I never use this on the papilla because it's the best way to reduce the edema during the healing of the wounds after the surgery. So using the piezo surgery device, it's possible to achieve a good clean using a particular ultrasound. As you can see from this piezoelectric drawing, as you can see. So with these physical characteristics, microaction and cavitation, it's possible to achieve a micrometric cut, selective cut, and to reduce ink during our surgery, because during the use of the piezo surgery device, I have always a very nice saline of the bone and of the soft tissue. So using these ultrasound waves, it's possible to achieve a micrometric cut to work with very high surgical control with great precision, also in the particular anatomical sites with high risk, for example, the sinus membrane, the vessel, and the nerve. And using cavitation effect, it's possible to reduce the bleeding and to achieve a very good surgical view. Microvibration, so using the microvibration, it's possible to see, as you can see from this image, a very conservative and precise cut. At the same time, using two different types of ultrasonic waves, it's possible the accumulation of the bone chips on the surface of the tips and to avoid the necrosis of the bone and the soft tissue. And again, the cavitation using the saline irrigation. And have a look these two different approach. This is the traditional approach, the ostectomy by the traditional drills. And this is the histological result. As you can see, we have a very important osteonecrosis area in this site. As you can see, instead, using the piezo surgery device for the cut, for the ostectomy, as you can see, we have different histological results with very minimal osteonecrosis area. So with this approach, it's possible to reduce the precise cut and to increase the healing of the bone and soft tissue. And have a look on the left and with the piezo surgery on the right. So as you can see, we have two different approaches. Using the straightened piece, it's possible to work quickly, as you can see, but at the same time, I remove very important part of the bone, as you can see. Instead, using the piezo surgery device, it's not possible to work quickly, but I removed a less part of bone. So it's very important, this difference, to achieve a better clinical result. Another clinical case, for example, the surgical approach of the lower third molar. This is the X-ray. In this case, I don't use the CBCT reconstruction because we haven't a close contact between the roots and the alveolar canal. But in other case, I need to have the CBCT reconstruction, not because I will change, but also I use the CBCT reconstruction for medical legal point of view. So this is the baseline situation. After the anesthesia, I make my triangular flap, the same approach. This is my surgical view. It's possible to see the crown of the lower third molar, two retractors to hold the flap, same approach always. Make the ostectomy, and now I remove it. I cut only the distal part of the crown to achieve the extraction of the dental elements, and I use the S-shaped retractor to remove the distal part of the crown. The residual alveolar cavity, very small cavity, to preserve the bone. Always I wash the cavity with the saline irrigation, I filled with the collagen, I make the suture, and this is the extraction. So removing the distal part of the crown, it's possible with the safe and this approach to remove the dental element altogether without other surgical approach. And now I will show a particular surgical case about the impacted tooth in close contact with odontoma in the mandible in very young patient, 15 years old. So it's very important to preserve the bone and to make a very minimal invasive approach because we are in the angle of the mandible. So it's very important to avoid the fracture of the mandible. So, as you can see from the CBCT reconstruction, we have a very big and large odontoma in close contact with horizontal impacted tooth. So I used the trapezoidal flap with the two vertical incisions to obtain a good surgical view and a good surgical approach, avoiding always, obviously, the emergence of the mental nerve. As you can see, now it's possible using the piezo surgery device to perform the bone window, to remove after the bone window, to cut after the odontoma, as you can see. So with the piezo surgery insert, I make the bone block, as you can see. Very easy and easy approach, especially very micrometric cut, as you can see. And now it's possible to remove the bone block, okay? And after, it's not possible to remove altogether the odontoma, but is, as you can see, using the same piezo surgery insert. So, very careful, I will remove the odontoma, as you can see, with different parts, using the hemostatic clamps to remove each parts, as you can see. This is very strong and hard tissue. We haven't bleeding in this site. I continue to remove the odontoma. This is the residual alveolar cavity. Now it's possible to approach on the impacted tooth in close contact with the mental nerve. So I cut the crown and the roots and I remove the dental elements. And always I filled the cavity with the collagen and I make the horizontal mattress on the posterior side and single suture in the anterior side. The X-ray post-op, but it's very important to see the healing weeks later. Very good healing also in this extreme and important case, using a piezosurgery approach. There are many studies about the use of the piezosurgery and this is my publication about this approach. And as you can see, using the piezosurgery, the pain to reduce the trisma, to reduce the swelling, to reduce the edema, and another my publication approach. And the only one disadvantage is the surgical time, because the piezosurgery device, it's not works quickly, but slowly. But I think it's not very important, because using this approach, it's possible to reduce the invasivity of our patient. And also the power that I use on the head of the piezosurgery device is very lower, about 500 grams. Instead, using the straight and the piece, I need to use about 2-3 kilograms of pressure on the head of the. It's very different approach and is very different use. Another case, I will show the maxillary approach to remove the lesion in the palatal site, as you can see. The CBCT reconstruction to show the exact position of the lesion, as you can see, in the palatal site. So it is start the palatal approach using another flaps design. In this case, I used the envelope flap. Without vertical incision, only intracircular incision, full thickness flap, with the nasopalatal canal. I use always the suture to hold the flap to achieve a good view, as you can see. And now I used a new particular piezosurgery insert. I check the depth about the lesion, and I continued with the insert, and now it's possible to remove the lesion, to preserve the bone, especially anatomical sites. So I remove the lesion, as you can see, using the Lucas curette. Okay. Same approach, I remove the residual tissue, I remove the residual part of the bone. In irrigation, I filled the collagen in the cavity, and I make the single nodes to achieve a good primary closure. So in this case, especially when I make the surgery in the, I use always the envelope flap. So we have different tips according to different surgical approach for the ostectomy, for the implant site preparation, for the distraction, for the implant, for the splitting, for the split crest, for the narrow ridge, for the implant site preparation again, for the maxillary sinus lift, for the implant extraction in case of, for example, of periimplantitis. But I use always this insert, for example, the ankylosis roots, the diamond shape, this very aggressive and sharp shape insert as you can see, for the ostectomy. This is the lab possible to make the ostectomy also deeper, especially in the lower teeth, the molar, or in the extraction of the lower dental elements. And another insert with this particular shape, it's possible at the same time and use the bone at the same time, for example, to preserve the alveolar cavity after the extraction. So one is certain for both uses. And this drawing shows the exact use of the piezo surgery insert. For example, during the ankylosis extraction, this is the correct use of the piezo surgery insert in close contact between the bone and the dental element to preserve the bone and to obtain a good space, a good ostectomy space between the dental elements and bone to achieve a good extraction, a nice extraction, to preserve, for example, during the implant placement after the extraction, because the critical site in the post-extractive implant is the buccal bone. So using this device, it's possible to reduce the buccal bone resorption and to place at the same time the implant with the lingual of the palatal approach to preserve the buccal side. So different use in different surgery. So I'd like to introduce my new textbook. Just came out in Italy few weeks, be available also in English version very soon, with the collaboration of Dr. Arungarg from Miami. And in this book, you can find more details about the surgical approach of the impacted teeth. And it's possible to buy this book also in Amazon if you want. So take kind attention.
Thank you, Angelo, for your step-by-step presentation on extraction, the impacted teeth, especially the third molar wisdom tooth. I truly enjoyed your minimally invasive approach in extracting these teeth, which sometimes they are not really easy to access. And if you want to go with high-speed rotaries or even contra angles, you know, it's not that safe. I mean, maybe it's easy to do it, but the surgeon's feeling is not that good. But with piezo surgery, it gives us a relaxation, a kind of confidence doing, especially in the very impacted tooth close to the vital structures like mental foramen, like inferior alveolar nerve, or etc. So I noticed that most of the molar wisdom teeth cases that you presented were mesioangular ones. So in cases that we have like horizontal impaction or distoangular tooth, sometimes the crown is toward to the lingual and not to the buccal. And the root is toward the buccal, the crown is toward the lingual. So in those cases, sometimes we have, we need to remove more bone to access the crown of the impacted tooth. I want to know what's your thought on that. Do you also start again with the piezo surgery in those cases that you have complete impaction and you don't have enough excess, or you prefer to start with low speed rotaries, and then when you reach close to the impacted tooth, change it to the piezo unit? I want to know your thought on that.
Absolutely, I agree. I think in this extreme case, for example, with the lingual approach of very extreme impacted teeth, I start always with the straightened peels to remove a little bit bone And after, I continue always with the piezo surgery insert, especially in particular site in close contact with, for example, with the lingual bone, with the lingual nerve, with the alveolar nerve. So I think it's very important to follow the complementary approach. But our goal is to preserve the anatomical structure and to reduce, especially in extreme case and in very dangerous case. I think this is the best solution.
So, speaking of cutting and sectioning the tooth for extracting the do you start to cut the enamel first with the low speed hand and then approach with the piezo unit, or you start from the very first? Because piezo units are not good in cutting enamel as far as I know. So I just wanted to know your thought on that too.
Yes, basically, I think to cut the crown in easy and in normal case, I will start always with the straight and piece with the traditional drills. But I continued in the lingual side in a particular case with the piezo surgery insert. But basically, I start always with the traditional drills, except in extreme case. For example, if I need to cut the roots in very close contact with the alveolar nerve. So in this case, I use directly the piezo surgery insert. But basically, to cut the crown, I use always the straight and the piece, the turbine and the traditional drills. Because I think we haven't more advantage in the cut of the crown, use the piezo surgery insert. The advantage using of insert is the ostectomy, to reduce the bone ostectomy. This is our goal, because reducing the bone ostectomy, it's possible to reduce the edema, to reduce the swelling, and to achieve a good healing of the bone and of the soft tissue, especially in the second molar, to avoid the invagination of the soft tissue, to preserve the distal bone around the distal side of the second molar, for example, in the lower or in the upper of the molar.
And one thing that I noticed, and actually me myself do it in most of my cases, not in all of them, I noticed that you put a collagen like a collagen, like a collagen sponge into the extraction sockets before suturing. So I wanted to, So because I believe that also it helps healing, and the tissue response will be faster by putting that, and it helps to stabilize the clots in the area of extraction usually. But I want to know your idea about it, because in my experience, whenever I inserted a huge collagen sponge into the extraction sockets, sometimes it interferes with the healing, and some patients reports a little bit of pain. But whenever I put a little sponge there, not a huge one to pack it there, the response of the patients was better. So I want to know your experience also on that.
Yes, in my experience, in my end, I use always in the post wisdom teeth, for example, I use always to compact the cavity with the sponge, with the collagen, for hemostatic reason, but especially to obtain a good plane of the soft tissue during the suture. And in my practice, I note always the same result, use the cavity using the sponge collagen. I think in some patients it's possible to act with systemic disease like diabetes, for example, for the alteration of the healing. So in this I prefer don't use the collagen in the cavity to achieve a good healing, but in particular patient with particular systemic disease. For example, the diabetes or the alteration of the systemic the alteration of the coagulation also. So I think basically I use always the collagen. In particular patient, it's possible to avoid the use according to the general state of the patient. So depend,
yeah. Angelo, I truly want to thank you for your time and for this great step-by-step, as I said, going into the detail of every case and show the audience the importance of the instruments, the delicacy of the flap, and how to approach minimally invasive to reduct the bone or do the ostectomies, and how to section the impacted teeth to be able to make it as minimally invasive as possible and maximizing the comfort of the patient after the surgery, which I believe is very, very critical, especially in removing the impacted teeth. So again, thank you for your time. Thank you for accepting the invitation. And I really enjoyed it and hope to see you very soon.
thank you very much for your kind invitation, and I hope to meet you very soon after this crazy period.
Yeah. Ciao, ciao. Thank you, my friend.
Thank you very much. From Italy. Bye bye.